Welcome back to the deep dive. If you've ever felt, a bit lost trying to sort out the sounds, the symptoms, the uh, surgical timings for valve disease, well, you're definitely in the right place today.
Yeah, absolutely.
We are taking on what I think is one of the most mechanically fascinating, but also clinically really complex areas in medicine, valvular heart disease.
It really is. It's kind of a maze, isn't it? Pressure flow, timing,
Mm-hmm.
it all gets tangled up.
Hmm.
And our sources today are, well, they're very clinical. High-yield summaries, basically, pulled from cardiology literature. We're jumping right into the deep end here.
Okay.
We'll be focusing on the definitions, pathophysiology, how things go wrong, management timelines, and crucially, those little details that help you differentiate,
Yeah.
like what separates a stable chronic issue from, bang, an acute surgical emergency.
Right. And that's really our mission today, isn't it? To provide that shortcut through the maze. By the end of this deep dive, hopefully you won't just memorize disease names. You'll actually get the mechanical reason why a patient shows up the way they do.
Exactly. And here's the core idea, the foundation for everything we're about to talk about. It simplifies things a lot, actually. Valve defects, fundamentally, they boil down to two main problems. That dictates everything else.
Okay, two problems. What are they?
Problem one, stenosis. That's just obstruction, narrowing. The valve doesn't open properly.
Right.
So the chamber before the valve, the upstream chamber, has to work way harder. This creates a massive pressure overload.
Pressure overload. Okay.
And number two,
Number two is regurgitation. The valve doesn't close properly. It leaks backward.
backflow.
Yeah, exactly. Backflow leakage. So now that upstream chamber has to handle way more volume than it was ever designed for. That leads to volume overload.
Pressure overload versus volume overload.
Yeah.
Got it. And the symptoms, the prognosis, when you need to intervene. It all hinges on which of those two problems you have. Which valve we're talking about, left side or right side, and maybe most importantly, whether the heart's had years to kind of adapt or if the failure just happened suddenly, acutely.
Okay, that makes sense. Let's unpack this then. Maybe start with the really dramatic stuff, the congenital issues we see right from birth. All right, kicking off with a really rare one, but definitely high stakes, tricuspid valve atresia.TA. If you run into this, say, on an exam scenario, the mechanism is pretty dramatic.
Mm.
What exactly defines TA, and why is spotting it so critical?
Well, tricuspid atresia is pretty much what it sounds like. It's a congenital cyanotic heart defect where the tricuspid valve is just absent. It never formed.
Absent, completely.
Completely. So there's literally no connection between the right atrium, the RA, which gets all that oxygen-poor blood back from the body, and the right ventricle, the RV, which is supposed to pump that blood to the lungs. Because the RV never gets any blood flow, it stays severely underdeveloped. It's hypoplastic.
Wow. Okay, that sounds, well, immediately fatal. If the blood coming back from the body can't get to the lungs for oxygen, how does an infant survive even, for a few hours?
That's the paradox, right? Survival is only possible if the body has these built-in escape routes, these shunts. The venous blood has to somehow bypass that blocked RA to RV path.
Okay, how?
It has to get out of the RA somehow. So the pressure builds up, and it forces the blood across an atrial septal defect, ASD, basically a hole between the atrium.
Right.
So the deoxygenated blood flows from the RA right into the left atrium, the LA.
So, okay, now you've got oxygen-poor blood mixing with the oxygenated blood coming back from the lungs, all in the left side of the heart.
Exactly.
And that immediately explains why these newborns are so blue, the cyanosis, it's severe, and it happens right away. The overall oxygen saturation is just low because it's all mixed.
Precisely. But, mixing the blood only solves half the problem. We still haven't figured out how to get blood to the lungs.
Right, the RV is tiny and useless.
Correct. So pulmonary flow has to come from somewhere else, usually relying on the strong left ventricle. This typically happens through one of two routes. Either there's a ventricular septal defect, VSD, which lets blood go from the powerful LV, maybe through the tiny RV remnant, and then out to the pulmonary artery. Or, probably more commonly, flow depends on a patent ductus arteriosus, PDA.
The connection between the aorta and pulmonary artery.
Yeah. That sends blood directly from the aorta after it's already mixed back to the lungs.
That specific kind of rerouted plumbing leads to some really interesting diagnostic clues, doesn't it? Especially on the ECG.
It really does. Because the right atrium is essentially blocked, it's pushing all that systemic venous return against resistance, trying to force it through that ASD.
Yeah.
So the RA enlarges dramatically.
And on the ECG?
You see tall, peaked P waves. That's the classic sign of right atrial enlargement. or RAE.
Okay, but RAE alone could mean other right-sided pressure issues. What makes TA unique here? The flow is all going left-right. That must change the electrical picture.
That's the absolute key differentiator. Because the left ventricle is now handling enormous volume overload. It's getting the normal return from the lungs, plus all that shunted systemic venous blood. It becomes the dominant electrical force.
Ah,
So it pulls the electrical axis way over to the left. The signature ECG triad for tricuspid atresia is therefore RAE. Those Hall keywaves combined with a really pronounced left axis deviation.
LED.
RAE plus LAD, that's unusual.
Very unusual. And then you add the chest x-ray finding, which typically shows decreased pulmonary vascular markings because the lungs are underperfused. Put it all together and you've pretty much nailed the diagnosis.
Okay, so diagnosis made, but in a cyanotic newborn, the clock is ticking really fast. What's the absolute first critical step in management before any kind of complex surgery happens?
You have to secure pulmonary blood flow. Since the PDA is often the main lifeline providing that flow, you absolutely must keep it open. So the management nugget is immediate prostaglandin E1 infusion.
Right, PGE1. Exactly. Prostaglandins stop the ductus from closing naturally, which buys the infant critical time, keeps oxygen saturation up until they're stable enough for the staged surgical repairs, like the Norwood or the Fond procedures. If that PDA closes before surgery, well, it's almost always catastrophic.
Okay, crucial first step. Now let's switch gears to something less severe maybe, but definitely more common. Another right-sided pressure problem, pulmonic stenosis, PS, usually congenital, right? And it's basically the RV struggling against a tight pulmonic valve.
Exactly. This is pure pressure overload for the right ventricle. And the effort the RV needs to push blood through that narrowed valve creates some very specific sounds.
What do we listen for?
Right after the first heart sound, S1, you often hear this sharp, high-pitched sound. It's the pulmonic ejection click.
Okay.
And that's immediately followed by the classic crescendo-decrescendo systolic murmur. It gets louder, then softer. Best heard at the left upper sternal border, the LUSB.
And here's where that famous breathing trick comes in, right? Why does taking a breath change right-sided murmurs like this?
It all comes down to venous return. When you breathe in, your diaphragm goes down, creating more negative pressure inside your chest. That acts like a vacuum, pulling more blood from the body back into the right atrium and then into the right ventricle.
So more blood fills the RV.
Which means more blood gets squeezed across that tight stenotic pulmonic valve during the next beat. That extra volume increases the turbulence.
Making the murmur louder.
Precisely. The murmur intensity increases with inspiration. That's a classic physical exam finding that helps confirm a murmur originates in the right side of the heart. Sometimes called the Carvalho sign, though we usually link that name more strongly with the tricuspid valve.
Okay. Now, pulmonic stenosis also messes with the second heart sound, S2. And that leads to an important differential diagnosis, particularly with atrial septal defect, ASD. How do we keep those two straight? They both affect the pulmonic area.
That's a great point. Both PS and ASD involve the right side, but they affect the timing of S2 differently. In PS, the obstruction delays the pulmonic valve closure. It takes longer for the RV to empty. So you get a widened split of S2. The aortic valve A2 closes, then there's a noticeable gap before the pulmonic valve P2 closes. And importantly, this split is variable. It widens even more during inspiration because that increased venous return further delays P2 closure.
Variable split in PS, how is ASD different? It's also a right-sided volume issue.
It is, but the volume load is constant. In an ASD, you have that continuous shunt of blood from the left atrium to the right atrium, meaning the right ventricle is always handling extra volume all the time.
Oh.
So the pulmonic valve closure is chronically delayed, making the split wide all the time, regardless of whether the patient breathes in or out. That's the key. A wide, fixed splitting of S2. If the split doesn't change with respiration, you should really think ASD. If it does change, think PS. That subtle difference on auscultation is incredibly useful.
Okay, that gives us a really solid handle on those congenital issues. Now let's pivot a bit and look at the acquired diseases, the ones that develop over time. Specifically, how the adult heart tries to cope, or sometimes fails to cope with pressure and volume loads building up over years. Let's head over to the left atrium and the mitral valve.
Yeah, the mitral valve is fascinating. Its problems are often like the end result of something that happened decades ago or sometimes a sudden, really dramatic mechanical failure.
Let's start with mitral stenosis, MSS. So this is narrowing of the mitral valve opening, making it hard for the left ventricle to fill during diastole, and the sources are clear. Worldwide, the most common culprit is still that rheumatic legacy.
Absolutely. Rheumatic heart disease,
Yeah.
RHD. It's a delayed, non-infectious consequence of an untreated group A strep throat infection, often something that happened way back in childhood or adolescence. It's an autoimmune reaction that causes chronic inflammation, then scarring, fibrosis, leading to thickening and eventually fusion of the mitral valve leaflets. This can take decades. The person might feel perfectly fine until they're, say, 30 or 40, and only then does the valve opening get tight enough to cause real problems.
And as that opening shrinks, the pressure starts backing up right into the left atrium. This back pressure seems to cause most of the symptoms.
Yeah, it's pure physics, really.
Right.
The left atrial LA pressure goes way up. That high pressure gets transmitted backward into the pulmonary veins. That causes pulmonary venous hypertension, leading to congestion in the lungs. Clinically, what does the patient feel? Progressive shortness of breath with activity, dyspnea, trouble breathing when lying flat, orthopnea, and sometimes, quite dramatically, hemoptysis.
Coughing up blood.
Yeah, actually coughing up blood. It happens when those tiny high-pressure pulmonary vessels rupture.
And if that pressure stays high long enough, it eventually affects the right side too.
It does. That sustained high pressure in the lungs leads to pulmonary arterial hypertension, which puts a huge strain on the right ventricle. The RV wasn't built for that kind of pressure. Over time, it fails. Then you start seeing signs of right-sided heart failure, swollen ankles, peripheral edema, bulging neck veins, JVD. It's a disease that starts on the left side, but often ends up causing failure on the right.
We definitely need to talk about the embolic risk with MS. It's a major stroke risk factor.
Oh, absolutely. It's like the perfect storm for clot formation. The chronically high pressure makes the left atrium stretch and dilate, sometimes massively.
Okay.
This stretching disrupts the normal electrical pathways, making the patient very prone to developing atrial fibrillation, AF.
The irregular heartbeat.
Right. And once the atrium isn't contracting properly, just kind of quivering, blood stagnates in that big dilated chamber, especially in the appendage. That's prime territory for a thrombus, a blood clot, to form.
And then it breaks off.
And it travels systemically,
Right.
often straight up to the brain, causing a devastating stroke. This is why finding AF in someone with mitral stenosis is a big deal. It demands immediate and usually lifelong anticoagulation, typically with warfarin, because the mechanical valve issue itself poses such a high risk.
Okay, let's talk sounds. The auscultation findings for MS are really unique, almost iconic in cardiology. What are we listening for at the apex of the heart?
Right. You need to listen during diastole when the LV is supposed to be filling. The first thing you might hear is the opening snap, OS.
Snap.
Yeah, it's this sharp, high-pitched sound. It happens when that stiff stenotic valve is suddenly forced open by the high pressure building up in the LA. The timing of that snap relative to the second heart sound, S2, actually tells you how severe the stenosis is. The closer the OS is to S2, the higher the LA pressure and the worse the MS.
Okay, opening snap. What comes after that?
Immediately after the snap, you hear the sound of blood struggling to get through that narrow opening. That's the low-pitched mediastolic rumble. Yeah, a rumbling sound. It's best heard right at the apex. You often need to have the patient roll onto their left side, the left lateral decubitus position, and really listen carefully with the bell of your stethoscope to pick up those low frequencies. It's a very characteristic sound. Opening snap, followed by a diastolic rumble. Classic MS.
Now, MS can often be managed for a long time, but you mentioned one situation where it becomes acutely dangerous. MS during pregnancy. Why is pregnancy such a huge, potentially lethal stressor for someone with a stenotic mitral valve?
Yeah, mitral stenosis is generally considered a major contraindication to pregnancy, unless it's very mild or has been surgically corrected beforehand. For these patients, pregnancy is just. It's a hemodynamic disaster waiting to happen.
How so? What changes?
Two huge things happen in pregnancy. First, the mother's circulating blood volume increases dramatically, sometimes up to 50% more blood.
Wow.
Second, and this is really critical for MS, pregnancy naturally increases the heart rate. Now, for a healthy heart, faster rate means more cardiac output. But for mitral stenosis, the narrowed valve needs time during diastole for blood to squeeze into the LV. When the heart rate speeds up, that diastolic filling time gets drastically cut short.
Not enough time to fill.
Exactly.
Yeah.
So the blood backs up even more severely into the LA. The LA pressure just skyrockets almost instantly. This leads directly to sudden, severe acute pulmonary edema and potentially cardiogenic shock. The heart simply can't handle the combination of increased volume and decreased filling time.
So any intervention, like a percutaneous balloon valvotomy, PMBV, to open the valve, absolutely has to happen before the patient even thinks about getting pregnant. It's essential pre-planning.
Non-negotiable, really. It's life-saving preparation. And this whole scenario highlights that key hemodynamic point about MSS. Even though the left atrial pressure and the pulmonary pressures are sky high, the left ventricular diastolic pressure itself is usually normal or even low.
Because the blockage is upstream.
Precisely. The problem is getting blood into the LV, not a problem with the LV itself, at least initially. Seeing high pulmonary pressure but normal LV filling pressure points you straight to the mitral valve as the culprit, distinguishing it from primary LV failure.
That pressure gradient is a fantastic clue. Okay, let's shift from blockage stenosis to the other main problem, leakage or regurgitation. So, mitral regurgitation, MRR. This is blood leaking backward from the left ventricle into the left atrium during systole, when the LV is supposed to be pumping forward. The classic murmur here is that blowing, high-pitched holosystolic murmur, meaning it lasts throughout systole, heard best at the apex, and often radiating out towards the axilla, the armpit.
Yeah, that's the classic description. But first, it's really important to figure out why it's leaking. We divide MR into two main types.
Okay.
Primary MR means the problem is with the valve leaflets or the supporting structures themselves. Think conditions like myxomatous degeneration. That's actually the leading cause in developed countries now. And it includes mitral valve prolapse.
Okay, floppy valve leaflets.
Yeah. Right. Or it could be leftover damage from rheumatic heart disease or destruction from endocarditis. The valve itself is intrinsically abnormal.
And the other type.
That's secondary or functional MR.
Yeah.
Here, the valve leaflets might actually be perfectly normal structurally.
Huh. Then why does it leak?
The problem isn't the valve, it's the ventricle. The left ventricle has become dilated, usually due to chronic conditions like cardiomyopathy or ischemic heart disease leading to heart failure. The LV gets so stretched out that it pulls the mitral valve annulus ring the leaflets attached to apart. The leaflets just can't meet in the middle anymore, so the valve becomes functionally incompetent, even though the leaflets themselves are okay.
Okay, that makes sense. Let's focus first on chronic severe MR, where the heart has had years to deal with this volume overload. How does it compensate?
So year after year of that extra volume leaking back into the LA, then coming back to the LV again on the next beat, it leads to massive LV volume overload. The heart tries to adapt by undergoing eccentric hypertrophy.
Eccentric hypertrophy. How's that different from the hypertrophy we'll talk about later?
It's volume-driven growth. The muscle fibers are added in series, kind of like adding links to a chain. This makes the chamber walls longer and, critically, makes the internal chamber size much, much larger. It dilates. This is different from concentric hypertrophy, which we see with pressure overload like aortic stenosis, where the wall thickens inward, making the chamber smaller but the muscle thicker.
Got it. Volume overload, echolation, eccentric. Pressure overload is thickening, concentric. And that big dilated chamber in chronic MR often gives us a specific sound clue, right?
It often does. An S3 gallop is really the hallmark sound of severe chronic volume overload states, including chronic MR.
What causes the S3?
It's the sound, or really the vibration, of those stretched, dilated LV walls as blood rushes in rapidly and passively from the LA during early diastole. Hearing an S3 is a strong indicator that the patient is dealing with significant volume overload and likely has reduced systolic function, even if the measured EF looks okay initially.
Ugh. Speaking of the EF looking okay, this brings us to probably the single most important high-yield surgical timing pearl in all of valvular disease, managing severe primary MR. The guidelines seem incredibly aggressive, pushing for surgery even when patients feel totally fine. Why the rush?
Because the standard measure of heart function, the left ventricular ejection fraction, LVEF, is dangerously misleading in chronic MR. It's a diagnostic trap.
Oh, so?
Remember, during systole, the LV has two ways to eject: forward into the high-pressure aorta and backward into the low-pressure left atrium. It's much easier to pump blood backward into the LA.
Path of least resistance.
Exactly. So a significant portion of the ejected blood goes backward, making the total amount ejected seem high. The EF calculation looks good, maybe even normal or slightly high, but it dramatically overestimates the actual forward cardiac output, the blood actually getting to the body. The heart looks like it's working well, but it's inefficiently spinning its wheels, dumping volume backward.
So if you wait until the EF drops significantly or until the patient develops symptoms,
it's too late. By then, the LV muscle has already suffered irreversible damage from years of chronic volume overload. Even if you fix the valve then, the LV may never recover proper forward function.
Wow.
That's why the guidelines are so clear. If a patient has severe primary MR, meaning the valve itself is the problem. Surgery, ideally valve repair. But replacement, if repair isn't possible, is indicated even if the patient is asymptomatic, if their LVEF falls into the range of 30% to 60%.
60%? That sounds pretty good.
It sounds good, but in the context of severe MR, an EF of 60% or less already signifies significant underlying dysfunction because so much of that ejection is going backward. Waiting for symptoms or waiting for the EF to drop below 30% means you've likely missed the window for optimal recovery. You have to intervene before the true dysfunction becomes obvious.
That's a critical point. The EF is basically lying to you in chronic MSR intervene while it still looks deceptively okay.
Precisely. You have to anticipate the decline.
Okay, now let's flip the coin entirely. Let's talk acute MMR. No time for compensation, just sudden, catastrophic leakage.
This is a completely different beast. It's often triggered by a sudden, dramatic event. The classic cause is rupture of a papillary muscle, usually the posteromedial one, a few days after an inferior wall myocardial infarction.
The heart attack damages the muscle holding the valve?
Right. Or it could be sudden valve destruction from aggressive infective endocarditis. The key is the like happens now.
So what happens inside the heart, particularly to the left atrium?
Total catastrophe. Unlike in chronic MR, where the LA has had years to stretch and accommodate the extra volume, in acute MR, the LA has no time to dilate.
Oh, no.
So this sudden massive gush of blood linking backward during systole hits a normal-sized, non-compliant LA. There's nowhere for it to go. The LA pressure spikes almost vertically.
And that pressure goes where?
Straight back into the lungs. It transmits instantly to the pulmonary veins and capillaries, causing immediate fulminant acute pulmonary edema. The patient basically drowns in their own fluids. And because forward output plummets, they often go into cardiogenic shock. It's a true surgical emergency.
And the diagnostic trap here is even worse than in chronic MR, isn't it? How does the LV look?
It's incredibly deceptive. Because the event just happened, the LV chamber size is usually completely normal on echocardiogram.
Normal size, but the patient's crashing.
Exactly. And worse, because the LV is ejecting so easily into that low-pressure LA sink, the calculated LVEF often looks hyperdynamic or misleadingly high. So you have a patient in florid pulmonary edema, in shock, but their echo might report a normal LV size and a high EF.
So you can't rely on those numbers at all.
Not in isolation. You have to put the whole clinical picture together. The sudden collapse, the massive pulmonary edema, maybe a new loud murmur, and despite that, a normal-sized, hyperdynamic-looking LV on the echo. That pattern screams acute MR.
Okay, from the mitral valve, let's move downstream to the final gateway out of the left ventricle, the aortic valve. And let's start with probably the most common severe valve problem we see in older adults in developed countries, aortic stenosis, the ultimate pressure cooker for the LV.
Yeah, AS is all about outflow obstruction. The LV is trying to pump blood out to the entire body, but the aortic valve is narrowed, calcified, and just won't open properly.
What causes it, usually?
It depends a bit on age. In older adults, say over 70, it's typically age-related calcification of a previously normal 3-leaflet tricuspid aortic valve, just wear and tear over decades.
Okay.
But if you see severe symptomatic AS in a younger person, maybe in their 50s or 60s, you should strongly suspect they were born with a congenital bicuspid aortic valve, BAV.
Only 2 leaflets instead of 3.
Right. That abnormal structure leads to turbulent flow and mechanical stress, causing the valve to wear out and calcify much earlier in life. So BAV is a major cause of AS in middle-aged adults.
Regardless of the cause, the poor left ventricle is now pumping against this massive resistance, like trying to push open a door that's mostly stuck shut. How does the LV adapt to that relentless pressure?
It adapts with concentric hypertrophy. Remember, we contrasted this with eccentric.
Yeah, eccentric was volume overload, dilation. Concentric is pressure overload.
Thickening, exactly. The LV muscle wall thickens inward. Sarcomeres are added in parallel. This makes muscle incredibly strong, allowing it to generate the super high pressures needed to force blood across the stenotic valve. It helps maintain wall stress initially.
But what does that do to the inside of the chamber?
It makes the chamber cavity smaller and the ventricle very stiff and non-compliant. It doesn't relax well during diastole.
Ah, and that stiffness is why you might hear an extra heart sound.
Precisely. That stiffness often leads to an S4 gallop. That's the sound of the left atrium contracting forcefully late in diastole, trying to push that last bit of blood into the stiff, resistant LV, the atrial kick against a non-compliant ventricle.
Okay. Now, AS can be silent for a long time, but once it becomes severe, typically defined as a valve area less than or equal to 1.0 square centimeter, the classic symptoms start to appear. There's that famous triad, what is it, and why are those three symptoms linked?
Right, the classic triad of symptomatic severe AS is angina, syncope, and dyspnea heart failure symptoms, usually remembered as ASD, angina, syncope, dyspnea. They all stem from the same fundamental problem: the heart's inability to increase its output adequately, especially during exertion because of that fixed obstruction.
Okay, let's break down each one. Why angina?
The massively thickened LV muscle, the hypertrophy, demands a huge amount of oxygen. But the fixed stenosis limits how much blood, and thus oxygen, can actually get out to feed the coronary arteries, especially when demand goes up with activity. So you get ischemic chest pain angina,
And syncope, fainting.
especially exertional syncope. When you exercise, your body needs more blood flow. Your blood vessels dilate. But the heart with severe AS simply cannot increase its forward output enough to meet that demand and maintain blood pressure, particularly to the brain. So blood pressure drops, perfusion to the brain falls, and the person faints.
And finally, dyspnea or heart failure symptoms.
That's usually the last stage. The super high pressures inside the stiff LV
Mm-hmm.
eventually back up. The diastolic pressure rises, that backs up into the left atrium, then into the pulmonary veins and capillaries.
Aortic congestion again?
Exactly. Leading to shortness of breath, dyspnea, initially with exertion, then later even at rest, progressing to full-blown heart failure. And the prognosis, once any of these three symptoms appear, is really grim without intervention. Survival is typically only 2 to 5 years.
Wow. Okay, the physical exam for AAS is also classic. That murmur is pretty hard to miss.
It really is. It's that harsh crescendo, decrescendo systolic murmur, sometimes described as diamond shape. It's loudest at the right upper sternal border, RUSB, and it characteristically radiates upwards, right into the carotid arteries in the neck. You can often hear it quite clearly there.
And what does that fixed obstruction do to the pulse you feel, say, in the carotids?
Because the flow is restricted and takes time to get through the narrow valve, the pulse feels weak or small in volume, parvis, and slow rising, delayed in its peak, tardis. So the classic description is pulsus parvis et tardis.
Small and slow pulse. Makes sense. What about the heart sounds? S2.
With severe calcific AS, the aortic valve leaflets are barely moving. So the sound of the aortic valve closing, the A2 component of S2, becomes very soft or even completely absent. This often results in a soft and single S2. You only hear the pulmonic component, P2. And as we mentioned, you might also hear that S4 gallop due to the stiff ventricle.
Okay. Given how dangerous symptomatic severe AS is, the definitive treatment is valve replacement, either traditional open heart surgery, SAVR, or increasingly the transcatheter approach, TAVR. But there's a huge warning sign, a major contraindication when managing these patients right.
Absolutely critical point. Exercise stress testing is strictly contraindicated in patients with suspected symptomatic severe AS. Because asking a heart that's already struggling against a severe blockage to dramatically increase its output during exercise is incredibly dangerous. It risks precipitating severe angina, syncope, dangerous arrhythmias, or even sudden cardiac death right there on the treadmill. The diagnosis and severity assessment must rely on clinical evaluation and imaging, primarily echocardiography, not provocative stress testing.
Okay, absolutely crucial safety point. Now let's flip from stenosis to leakage at the aortic valve.
Right.
Aortic regurgitation, or
AR, sometimes called aortic insufficiency. This is when the aortic valve doesn't close properly, allowing blood that was just pumped out into the aorta to leak backward into the left ventricle during diastole.
So like chronic mitral regurgitation, this is going to be a volume overload problem for the LV.
Exactly. The LV has to handle the normal amount of blood coming from the LA, plus all the blood leaking back from the aorta. This leads to massive LV volume overload over time, causing that same eccentric hypertrophy dilation and enlargement of the LV chamber that we saw with chronic MISVR.
What's the most common reason for chronic AR these days, especially in developed countries?
Again, similar to AS in younger folks, a leading cause is failure of a congenitally bicuspid aortic valve, BAV. It just doesn't seal properly over the long term. Other causes include dilation of the aortic root itself, maybe from hypertension or connective tissue diseases, or sometimes acute causes like aortic dissection or endocarditis destroying the valve.
Okay. Now, chronic AR produces some of the most, spectacular peripheral physical exam signs in all of cardiology. They're all related to the wide pulse pressure, right? Can you explain why the pulse pressure gets so wide?
Sure. Pulse pressure is just the difference between systolic and diastolic blood pressure. In severe chronic AR, two things happen. First, the LV is massively volume overloaded, so when it contracts, it ejects a huge stroke volume, leading to a very high systolic pressure.
Okay, high top member.
Right. Then, during diastole, a large amount of that blood leaks right back out of the aorta into the LV. This causes the pressure in the aorta to plummet, leading to a very low diastolic pressure.
Low bottom number. High systolic, low diastolic.
Equals a very wide pulse pressure. That large difference is the key.
And that huge swing in pressure creates those famous bounding pulses.
Exactly. The pulse feels incredibly forceful, bounding, and then collapses rapidly because the diastolic runoff is so significant. There are lots of classic eponyms for these signs.
Like the water hammer pulse.
Yeah, the water hammer or Corrigan pulse. You feel it often in the radial artery, this really rapid, sharp upstroke followed by a sudden collapse. And you might hear pistol shot sounds, Traub sign, if you listen with a stethoscope over the femoral artery. These loud, sharp, booming sounds with each pulse. They're all signs of that hyperdynamic circulation and wide pulse pressure.
What does the patient themselves often complain about? What sensation might they feel?
Patients with significant chronic AR often report feeling palpitations or a very noticeable, sometimes uncomfortable pounding heartbeat, especially when they're lying down, particularly on their left side. They can literally feel that hyperdynamic enlarged LV thumping against their chest wall because the stroke volume is so large. That subjective feeling is a really important clinical clue.
Okay. And finally, the diagnostic rule of thumb when you hear the murmur of AR.
Right. The murmur itself is typically a high-pitched, blowing, early decrescendo diastolic murmur.
Yeah.
It starts right after S2, when the valve is supposed to close, and fades away during diastole. It's often best heard along the left sternal border.
And the imperative.
The absolute rule is all diastolic murmurs are considered pathological until proven otherwise. Unlike some systolic murmurs, which can be benign, a diastolic murmur always signifies underlying structural heart disease. If you hear one, like the murmur of AR, it mandates prompt investigation, usually starting with an echocardiogram. You can't just watch and wait with the diastolic murmur.
Okay, let's pivot now to a major threat that can complicate any underlying valve disease or even affect normal valves, infective endocarditis, i.e. This can turn a stable situation into an immediate crisis.
Absolutely. I.e., an infection of the heart valves or lining causes rapid, often aggressive destruction of the valve tissue,
Leading to
severe acute regurgitation, either worsening of pre-existing leakage or creating a new leak on a previously normal valve. And as we just discussed with acute MR and potentially acute AR, sudden severe regurgitation leads to immediate heart failure.
So what's the most critical takeaway regarding IE and heart failure?
The single most important point is that heart failure due to acute valve destruction is the leading cause of death in patients with infective endocarditis. Antibiotics alone are often not enough in this situation. These patients frequently require urgent, sometimes emergent surgical intervention to replace the destroyed failing valve and remove the source of infection. Delaying surgery in the face of heart failure significantly worsens outcomes.
Okay, urgent surgery for HF in IE. Now, there's a specific pattern of IE we often associate with 5E drug use, IVDU. How does that typically present?
Yes, IVDU has a strong association with right-sided IE. The infection usually involves the tricuspid valve, TV, and sometimes the pulmonic valve.
Why the right side?
Because the injected material, potentially contaminated with bacteria, enters the venous system first, goes straight to the right side of the heart. The causative organism is often a particularly nasty one, typically Staphylococcus aureus, which is common on the skin and can be introduced during injection.
And those infected clumps on the valve, the vegetations, they don't just stay there, do they? Where do they go?
No, they're often quite friable. They break off and travel downstream with the blood flow.
From the right side of the heart, where does blood go next?
Up to the lungs. Exactly. So the classic complication of IVDU-associated right-sided IE is septic pulmonary emboli. Bits of infected vegetation lodge in the pulmonary arteries. On a chest X-ray, this often appears as multiple scattered peripheral lung nodules, which frequently cavitate, develop holes in the center, as the infection progresses. Seeing that pattern should immediately make you think of right-sided endocarditis, especially in the patient with the risk factors.
We mentioned the Carvalho sign earlier when talking about PS. Let's nail down the specific finding for tricuspid regurgitation, TR murmur, which we might hear in right-sided IE.
Right. The murmur of TR is typically holosystolic, heard best along the left lower sternal border, LOSB. And the key diagnostic clue is that its intensity should increase significantly with inspiration, That's the Carvalho sign for TR.
Why does inspiration make it louder again?
Same reason as with PS. Inspiration increases venous return to the right heart. More blood fills the RV, so during systole, more blood regurgitates backward across the leaky tricuspid valve, intensifying the murmur.
Got it. Now, shifting back to the left side, if infective endocarditis hits the aortic valve, there's a particularly dangerous complication that can happen because of where the aortic valve sits anatomically.
Yes, this is the conduction connection risk. The aortic valve annulus, the fibrous ring that supports the valve leaflets, sits right next to the heart's critical electrical conduction system, specifically the AV node and the bundle of His, which run nearby in the septum.
So if the infection spreads,
If the IE infection burrows outside the valve leaflets into that surrounding annular tissue, it can form a perivalvular abscess. This abscess can then directly invade or compress the adjacent conduction system.
and what's the warning sign that this dangerous extension has occurred?
The hallmark clinical sign is the development of a new AV conduction abnormality in a patient known to have aortic valve endocarditis. This could be anything from a new first-degree heart block to complete heart block. Seeing new conduction block in aortic IE is a red flag for an abscess and usually necessitates urgent surgery.
And if you suspect an abscess or need to get a really good look at the valves, especially prosthetic ones, is a standard transthoracic echo, TTE, good enough?
Often, no. While TTE is the usual starting point, transesophageal echocardiography, TE, is significantly better for visualizing certain things.
Like what, specifically?
T provides much clearer images of the posterior heart structures, including the valve annuli, making it far superior for detecting perivalvular abscesses. It's also much better at visualizing vegetations on prosthetic valves, where the acoustic shadowing from the artificial material can make TTE very difficult to interpret. If you have high suspicion for IE complications, especially on a prosthetic valve, TE is often essential.
Speaking of artificial valves, let's talk about prosthetic valve endocarditis, PVE itself, and the need for prophylaxis. Once someone gets any kind of prosthetic, heart valve, mechanical, bioprosthetic, even one placed via TAVR, what's their long-term risk of getting endocarditis on that valve?
The risk of PVE, unfortunately, persists indefinitely. It is a lifelong risk. That artificial material, whether metal or tissue, remains a foreign body and a potential surface for bacteria circulating in the bloodstream to latch onto and cause infection. Patients need to be aware of this risk forever.
Okay, lifelong risk. So what does that mean for preventing infection? When do these patients absolutely need antibiotic prophylaxis? Before certain procedures?
Right, prophylaxis is crucial. The guidelines recommend antibiotics, typically a single dose of amoxicillin, 2 grams orally, about an hour before the procedure for specific high-risk procedures where significant bacteremia, bacteria entering the bloodstream, is likely.
Which procedures qualify as high risk?
The main ones are procedures involving manipulation of gingival tissue or the periapical region of teeth, or perforation of the oral mucosa. So routine dental cleanings, tooth extractions, periodontal procedures, those definitely require prophylaxis. Also procedures on the respiratory tract mucosa, like tonsillectomy or bronchoscopy with a biopsy, and procedures on infected skin or musculoskeletal tissue.
Okay, dental work is key. What about common procedures that people often ask about, like GI procedures? Do they need prophylaxis for, say, a colonoscopy?
This is a common point of confusion. For routine gastrointestinal or genitourinary procedures, like a screening colonoscopy or a standard cystoscopy, antibiotic prophylaxis is generally not recommended unless the procedure is being done in the setting of an active infection in those systems. The risk of clinically significant bacteremia causing endocarditis from these procedures is considered very low.
Good to clarify. Finally, what if a patient with a known prosthetic valve develops a new heart murmur? How should that be handled?
A new murmur in a patient with a prosthetic valve is a potential emergency. It must trigger an immediate evaluation for prosthetic valve dysfunction, PVD.
What could be causing it?
It could be several serious things. Thrombus, clot formation on the valve restricting its movement, perivalvular leak where the valve stitches have come loose from the heart tissue, or PVE, endocarditis itself causing valve damage or leakage. You cannot simply monitor a new murmur in this setting. It demands urgent assessment, starting with an echocardiogram, often both TTE and TE, to figure out what's wrong and determine if intervention is needed.
All right, to wrap things up, let's touch on a few diagnostic curveballs, some less common conditions or specific scenarios that can mimic valve disease or present challenges in diagnosis. Starting with a complication sometimes caused by our own treatments, tricuspid regurgitation after putting in a pacemaker, or ICD.
Yes, this is something we're seeing more often as more devices are implanted. Those pacemaker or implantable cardioverter defibrillator, ICD, leads have to physically pass from the veins through the right atrium and across the tricuspid valve to sit in the right ventricle apex.
And the lead itself can cause problems.
It can. Over time, the lead can physically impinge on the tricuspid valve leaflets, preventing them from closing properly, coapting, or sometimes it can directly damage a leaflet or the chordae. This can lead to new or significantly worsened severe tricuspid regurgitation, TR.
And how would the patient present? What clinical signs would point back to the device lead as the cause?
They typically develop symptoms and signs of new onset right-sided heart failure that weren't present before the device was implanted or that develop progressively afterward. Increasing jugular venous distension, JVD, worsening peripheral edema, leg swelling, maybe ascites, fluid in the abdomen, and hepatomegaly, an enlarged congested liver. If you see that pattern after device placement, you have to consider lead-induced TR.
Okay, good clinical pearl. Next, let's talk about probably the most dynamic murmur out there, mitral valve prolapse, MVP. It's famous for its sound and how dramatically it changes with maneuvers.
Right. MVP is usually caused by myxomatous degeneration, where the mitral valve leaflets are abnormally thick, redundant, and floppy. During systole, instead of staying shut, they prolapse or billow backward into the left atrium.
And the classic sound.
The hallmark is the midsystolic click. This is thought to be caused by the sudden tensing of the elongated chordae tendineae as the floppy leaflet reaches its maximum point of prolapse.
This click is often, but not always, followed by a late systolic murmur of mitral regurgitation as the valve starts to leak after the prolapse occurs.
Okay, click, maybe followed by a late murmur. But the really key thing is how it changes with volume, right? The volume test.
Exactly. This is what makes MVP diagnosis often very reliant on the physical exam. The timing of that click and the duration loudness of the murmur depend entirely on the left ventricular volume.
How so? Let's take low volume first, like standing up or doing a Valsalva maneuver.
Right. Maneuvers that decrease venous return, like standing or Valsalva, make the LV chamber smaller. A smaller ventricle contracts more quickly and reaches the point where the leaflets prolapse sooner in systole. So the click moves.
The click moves earlier in systole, closer to S1. And because the prolapse happens earlier, the subsequent MRR murmur starts earlier and lasts longer, often becoming louder.
Earlier click, longer, louder murmur with low volume. What about high volume, like squatting?
Squatting increases venous return and afterload, making the LV volume larger. A larger, fuller ventricle takes longer to contract down to the point where the leaflets prolapse.
So the click moves.
The click moves later in systole, closer to S2. Sometimes, if the volume increase is significant, the click might even disappear altogether. And the murmur, if present, starts later and is shorter and often softer.
Later click, shorter, softer murmur with high volume. That dynamic response is really the key to differentiating MVP from other systolic murmurs like AS or fixed Bingar.
It's incredibly helpful at the bedside, yes.
Okay, now we talked about infective vegetations earlier. What about sterile ones? Tell us about non-bacterial thrombotic endocarditis, NBTE.
Right, NBTE is quite different from IE. Here you get small, sterile vegetations forming on heart valves, most commonly the mitral or aortic valve. These are made up of just platelets and fibrin, no bacteria, no inflammation.
Sterile vegetations. Why do they form? Not infection, so what's the trigger?
The trigger is usually an underlying hypercoagulable state. There are two main clinical associations you need to remember for NBTE. First, advanced malignancy, particularly mucin-producing adenocarcinomas, like pancreatic or lung cancer. This is sometimes called merantic endocarditis.
Cancer-associated hypercoagulability, okay? And the second association?
Certain systemic autoimmune conditions, especially systemic lupus erythematosus, SLE, particularly if associated with antiphospholipid syndrome. The inflammation and antibodies in these conditions can make the blood clot more easily on the valve surface.
How does NBTE usually present clinically, and how do we tell it apart from regular infective endocarditis?
NBTE itself is often clinically silent. The vegetations are usually small and don't cause significant valve dysfunction or murmurs initially. The major problem arises when these sterile, friable vegetations break off and cause systemic embolization.
Ah, so strokes or infarcts in other organs?
Exactly. Patients might present with a stroke or infarcts in the spleen, kidneys, or limbs. The key differentiating features from IE are what's missing. In MBTE, there is typically NO fever and no signs of infection like leukocytosis, high white blood cell count, and blood cultures will be negative. Management isn't antibiotics, it's anticoagulation to prevent further emboli, and crucially, treating the underlying cause, the cancer or the autoimmune disease.
Okay, sterile emboli from cancer or autoimmune disease. Got it. Now, another thing that can mimic valve disease, particularly mitral stenosis, is a tumor inside the heart, the cardiac myxoma.
Yes, the myxoma is the most common primary tumor of the heart in adults, and thankfully it's usually benign. About 75% of them occur in the left atrium.
And how does it mimic mitral stenosis?
They're often pedunculated, meaning they're on a stalk, and they can swing back and forth with blood flow. During diastole, the tumor can actually flop down and obstruct the mitral valve opening, preventing blood from easily entering the LV.
So it causes symptoms of obstruction, like MS?
Exactly. Patients can present with dyspnea, fatigue, syncope, and even a diastolic murmur that sounds very much like the rumble of MS. They can also be a source of emboli at bits. Bits of the tumor can break off and cause strokes, similar to a thrombus in AF or MBTE.
But there's a unique clue with myxomas, something systemic that you don't usually see with simple MS or a blood clot, right?
Yes, this is really important. Myxomas are metabolically active tumors, and they can secrete inflammatory cytokines, most notably interleukin-6. IL-6.
And IL-6 causes?
It causes systemic constitutional symptoms. Patients with an atrial myxoma often present with things like unexplained low-grade fever, significant weight loss, fatigue, muscle and joint aches, arthralgias, myalgias, and laboratory findings like anemia and a very high erythrocyte sedimentation rate, ESR, or C-reactive protein, CRP.
So if you see someone with signs of mitral valve obstruction plus these systemic inflammatory symptoms, you have to think myxoma.
Absolutely. It's a critical distinction because myxomas require prompt surgical resection. Leaving them in place risks further embolization and obstruction.
Okay. Lastly, let's end on a reassuring note. Let's talk about innocent murmurs, especially in kids. We don't want to cause unnecessary worry or order tons of tests for benign sounds.
Definitely not. It's crucial to be able to recognize the common, completely benign flow murmurs.
Yeah.
The most classic one in children is Still's murmur.
What does stills sound like?
It's typically described as a low-pitched, vibratory, or musical-sounding murmur. It's mid-systolic, usually best heard between the lower left sternal border and the apex.
And how does it behave?
The key is that it's usually loudest when the child is lying down, supine, and it significantly decreases or disappears when the child sits up, stands, or performs a Valsalva maneuver. That change with position is very characteristic. If a murmur has all these classic features of Still's in an otherwise healthy child, the management is simply reassurance. No further workup needed.
Okay, Still's murmur is benign. What about newborns? Sometimes they have murmurs too?
Yes. Another very common and innocent murmur, this one heard in newborns and young infants, is called peripheral pulmonary stenosis, PPS.
What causes that?
It's simply due to the normal anatomy of the pulmonary arteries right after birth. The main pulmonary artery is relatively large compared to the branch pulmonary arteries going to each lung, and the angle where they branch off is quite sharp. This causes some turbulence as blood flows into the branches.
And the sound.
It's a soft systolic ejection murmur, usually heard best at the upper left sternal border. But the unique feature is that it often radiates quite widely sometimes to both axillae, armpits, and even to the back.
Radiates to the back. Oh.
Again, this is considered a normal physiological finding in early infancy. As the pulmonary arteries grow and remodel, the murmur typically disappears on its own within the first few months of life. So like Still's, classic PPS just requires reassurance. Hashtag outro.
Wow. Okay. We have covered a ton of ground today, really navigating that hemodynamic maze, as you called it. Everything from, congenital defects needing a PDA lifeline to acquired diseases pushing the LV to its absolute limits. Let's just quickly hit those absolute must-know high-stakes takeaways one more time.
Yeah, definitely. I think number one, remember the crucial difference between acute versus chronic regurgitation. Acute failure hits a normal-sized, unprepared chamber, causing shock. Chronic failure gives the chamber time to dilate and compensate, at least for a while.
Okay. Acute versus chronic leakage. Got it.
Number two, know that deadly triad of severe aortic stenosis, angina, syncope, dyspnea. Symptoms mean the clock is ticking and valve replacement is needed urgently. Don't do an exercise test.
Right. ASD triad equals danger.
Number three, don't be fooled by the LVEF in severe primary mitral regurgitation. That EF is artificially inflated. Surgery is often needed before symptoms appear or the EF drops into the truly bad range, ideally when it's between 30 and 60%.
The EF lies in chronic primary MFR.
Okay. And maybe number 4, for anyone with a prosthetic valve, remember that the risk of endocarditis is lifelong, and prophylaxis for high-risk procedures, especially dental work, is absolutely essential.
Lifelong risk, lifelong vigilance. Great summary.
Reflecting on all this, it's striking how often valve disease is this silent battle inside the body. The heart compensates brilliantly, sometimes for decades, managing incredible pressure or volume loads, until suddenly some major stressor, maybe an acute MI damaging a papillary muscle or the volume load of pregnancy, or a bloodstream infection seeding a valve, just pushes the whole system over the edge past its limits of compensation.
Yeah, the compensation hides the underlying problem until it breaks. Which I guess brings us to our final provocative thought for you, the listener. Given that so many of these acquired valve diseases really start incredibly subtly, think about rheumatic heart disease, maybe starting from a single untreated strep throat in childhood that nobody even remembered. Or the slow, silent calcification happening over decades on a bicuspid aortic valve someone didn't even know they had. Makes you wonder, doesn't it? What overlooked, maybe seemingly minor non-cardiac symptom today could actually be the very first subtle whisper of tomorrow's life-threatening valve failure.
Yeah, like that persistent low-grade fever in an adolescent that was never quite figured out, or maybe some transient joint aches that got written off as just growing pains.
Yeah.
Could that have been the initial rheumatic fever episode?
Exactly. The story behind a diseased valve often begins long, long before anyone ever hears a murmur. It really forces you, as you said earlier, to consider the whole timeline, the whole history behind every diagnosis.
It absolutely does.
Yeah.
A good reminder to keep digging.
Indeed. Well, that's all the time we have for this deep dive. Until next time, keep digging deep.